My name is Thileepan Naren. I'm an addiction medicine specialist and chair of the National Prison Addiction Medicine Network. And I'll be talking about how the National Prison Addiction Medicine Network came up or formulated a consensus statement around opioid agonist therapy in custodial settings. I'd also like to acknowledge on this slide as well the great work that one of our addiction medicine advanced trainees, Jocelyn Chan, did in largely doing a lot of the literature review, a lot of the grunt work, and also helping with the formulation of this slide pack. So acknowledgements to Jocelyn here as well. Just a quick conflict of interest statement as well. I have previously received speaking honoraria from Cameras. I don't think it impacts any of this presentation, but just thought I'd put it out there as out of an abundance of caution. And I also would like to make a quick acknowledgement of country as well. I'm also in Melbourne on the lands of the Wurundjeri people of the Kulin Nation. And I'd like to pay my respects to Aboriginal elders past, present and emerging, and any Aboriginal and Torres Strait Islander people who are joining us on this webinar. So I guess a quick backstory or a bit of background as to what led to the formulation of this body of work. So we know in general, and there's a lot of literature around opioid agonist therapy and opioid agonist therapy in custodial settings. We know that when patients are initiated and maintained an opioid agonist therapy in prison, there's a very high likelihood of continuation in the community. Risk of fatal overdoses are decreased significantly when people are on opioid agonist therapy, and we know that that time period immediately post-discharge, the first 2 to 4 weeks post-discharge, are the highest risk time period for fatal overdoses for people. And we also know that a large number of people who come into prison who inject drugs will leave prison and resume injecting drugs. So essentially, the need for identification of patients with opioid use disorder, the prompt treatment of patients with opioid use disorder, and the offering of opioid agonist treatments to people with an opioid use disorder in a custodial setting is paramount. However, as we all know, that varies depending on which jurisdiction one is in, and sometimes even if one is in the same jurisdiction, depending on what prison one is in, that can also impact what people are offered and the treatments that people are offered as well. But I guess this slide is just the background of the high imperative and the need for prompt identification, offering of treatment, and also the continuation of treatment post the incarceration time period. And again, without saying anything that I think is going to be too controversial here as well, we know that drug use in prisons is a very highly prevalent issue. Half of all incarcerated people use drugs in prisons, and a large number inject drugs in prisons as well. And we also know that there is no real national coordination or even state-based coordination sometimes in terms of withdrawal management and the management of substance use disorders, even between police cells and prisons. And there certainly is no national consensus in the management of withdrawal from substances, but also in the management of opioid agonist therapy, which is the thing that I guess I will be spending most of this presentation talking about. So the National Prison Addiction Medicine Network was created in August of 2023 to basically combat the issues I've kind of outlined on the previous slides. And that was that it was identified that there was a massive gap in the treatment of patients who had substance use disorders, who were undergoing withdrawals in custodial settings, and the fact that a lot of us in our different states and territories were practicing or doing things that were sometimes quite discordant with what other people were doing, and sometimes even the treatment options and interventions available in different states and territories varied quite widely. And the goal of the network was to try and create some consensus guidelines around various domains, and I've listed the 7 main domains that we were aiming to try and focus our attention on, but mainly around withdrawal management, opioid agonist therapy, harm reduction interventions, and also, and quite widely, and sometimes it's not really talked about enough, the discharge planning and transition from the prison sector into community-based care, because we certainly do see a large drop-off in patients in terms of accessing healthcare, and even patients with quite significant both mental and medical comorbidity falling through the gaps as well. So the National Prison Addiction Medicine Network is kind of led or managed by Western Health and the Burnett Institute. And through that and various stakeholders, we are formulating various guidelines, as mentioned. We have completed the opioid agonist consensus statement. I will talk about that throughout this presentation. And our next body of work is the withdrawal management consensus statement. So with regards to the opioid agonist consensus statement, the way this worked was we assembled an expert panel. A literature review was performed of the available literature around opioid agonist therapy in custodial settings. And then through kind of a modified Delphi method, we went through a couple of iterations of voting to form what we thought would be consensus and what was acceptable. And as with any consensus statement, there is always an element of compromise. And sometimes for the more progressive, it might not be as progressive potentially as some people would want, but it's certainly a baseline level of which, for lack of a better term, standards can be commenced from, and then further iterations can go from there. So this was the initial timeline and how long it kind of took to get to the level where we're at right now. And I'm more a clinician than an academic, and I initially thought we could push this out in a couple of months, but that proved to be vastly underestimated. So the literature review was started in November. The draft recommendations and the grade assessments of those recommendations were made around January. We obtained expert opinion and recommendations and reviews of the draft over a few months, and then voting took place. And the statement ultimately was finalized in July and submitted for publication in August. So all in all, it took around 8 to 9 months to kind of get to stage of publication. So the following table is a list of the people who were part of the expert panel. Of note, we have all the states and territories represented, usually from the custodial medical health lead within each of the states. We also have relevant members from the expert colleges as well. We have a representative from the College of GPs, College of Psychiatrists, and College of Physicians as well. We also have different craft groups involved as well. So we have a nursing representative, a pharmacist representative as well as a member from AVIL providing a consumer perspective as well to kind of govern some of the recommendations that we've made as well. And again, for the acceptability of the consensus statement, it was important for us to get as wide an expert panel as possible to make sure that this was applicable to all the states and territories, and that this was not just going to be a document that could be filed away, but something that could hopefully be used to implement change, and something that the stakeholders would be happy to kind of take to their different state and territory jurisdictions and advocate for. So the actual method of getting to the consensus statement involved the research team reviewing the literature and providing a draft of the recommendations and grading the evidence and the evidence quality, and then grading some of the recommendations as well subsequent to that. It involved a lot of toing and froing with emails from the expert panel to kind of send a draft, get feedback on the draft, and then workshop what the recommendation would look like. And then after that, there was some online meetings and then also surveys to endorse the recommendations. We defined consensus as 80% agreement by the expert panel of the recommendation, and the voting was again done through anonymous online polling, which we felt would better enable people to vote how they felt fit, rather than just the peer pressure kind of non-blinded voting system. So the literature review involved going through PubMed. The search terms are listed here on your slides as well. And we tried to kind of keep it to the most relevant recent literature. And then we also supplemented some of that information with some of the grey literature that our panel members were able to provide, including local, state, territory guidelines or processes for how they would manage patients with opioid use disorders, or the protocols that were used to treat people on opioid agonist therapy in their states and jurisdictions as well. So literature review and grey literature certainly serve to kind of guide some of the literature review and the recommendations as well. So this is again a bit of a breakdown of the panel. So again, pretty even gender mix, pretty wide range of fields of employment as well. And essentially, and pleasingly, every single member took part in at least one of the components of this as well. So there was no one who really abstained from anything. And 89 or 90% of people took part in more than one of the surveys as well. So we got a pretty good baseline. So these are the actual recommendations, and the grade there says how the voting for the recommendations. U represents unanimous, A represents greater than 90% agreement of the recommendation, and B represents greater than 80% recommendation. Pleasingly, we got consensus on all of the recommendations I'm about to show you, and a lot of these were unanimous. So with regards to the induction or continuation of opioid agonist therapy, it was unanimously agreed that people should be continued on OAT without interruption if they came into the correctional setting on opioid agonist therapy. And it was also unanimously agreed that people should be assessed for opioid withdrawal within 24 hours and monitored by an appropriately qualified healthcare professional within at least 72 hours following detention. Some of these numbers kind of can seem a bit arbitrary, but they were also shaped by what was feasible in some locations where the access to healthcare providers can be a bit more limited than in other jurisdictions as well. So that, like I said, the aim for this was to be as practicable as possible, and also as an advocacy piece for some of the jurisdictions where there is a much more significant weight as well. So that's essentially the induction or continuation of opioid agonist therapy, series of recommendations there. So with regards to the administration, the options and administrations, I think this is the only B recommendation. So this is the one that was probably the most controversial, which was around medication choice, where some jurisdictions felt that the healthcare provider should make the choice, and other people felt a lot more strongly that the patient, the consumer, should at least be offered some choices as well. We all know that there are some significant restrictions around particularly Suboxone in custodial environments, but even within different state and territories, there are still further restrictions as well. So that was probably the most, 2.1 was the most probably controversial recommendation. Everyone felt, usually for practical or utilitarian reasons, that LAIB administration or access to LAIB should be increasingly facilitated as well. And also we felt that, obviously discontinuing or withholding opioid agonist therapy as a disciplinary measure should not be enforced as well. Being on OAT is not a privilege, and it should not be revoked if one is not behaving in a quote-unquote appropriate manner. Regarding the recommendations around transition of care to the community, it was again unanimously felt that patients should be linked into a community-based OAT provider to help facilitate the ongoing provision of OAT. And as we know, in the immediate post-discharge time period, with the increased risk of overdose or fatal overdose, this is paramount to ensure the safety of our patients. And the importance, again, of appropriate bridging scripts of a sufficient duration as well. And we settled at 4 weeks supply. A lot of jurisdictions have 1 week or sometimes less, sometimes more. And that sometimes is just not, especially that post-release time period, it's just not practical or feasible for patients who've often got competing demands to try and get into a community OAT provider as well. And we also felt that it was important to ensure that takeaway doses were provided for patients if pharmacies were closed, and not to insist on supervised dosing as well if the pharmacy was not able to facilitate that. And then again, the importance of increasing access to take home naloxone was again unanimously agreed upon. With regards to special populations, again, the need to kind of make sure that the care we provide is appropriate to the people that we give care to, and the importance of collaborating with people, especially Aboriginal and Torres Strait Islander communities, and also the importance of trying to commence women who are pregnant with opioid use disorders on opioid agonist therapy as soon as practicable. Coming up to organisational support, I think this is almost the last section of the consensus statement. It's important to kind of continually reevaluate local policies around OAT and make sure that these are up to date and that it's meeting the needs of people as well, and that there's ongoing sustained funding to support the provision of OAT service delivery, particularly in custodial settings. And it's certainly important that services monitor their own systems, including how often people are being screened for opioid use disorder, the wait time to access review, the wait time to access OAT, how long people are retained, and anything that can improve quality improvement for OAT programs is again vital. So these again were unanimously supported recommendations. Now, with regards to the dissemination of this statement, so it's been accepted for publication in the Medical Journal of Australia. The final galley proof has just been approved, so hopefully it'll be published in the next couple of months. We have presented a couple of abstracts of this at the ISBRA conference and APSAD already. We have formal endorsement of the consensus statement from AVIL, the Pharmaceutical Society of Australia, the Royal Australian College of Physicians, APSAD, and the National Prison Hepatitis Network. So they've read the complete document and are happy to approve it. And it's also been approved as a supported and accepted clinical resource by the Royal Australian and New Zealand College of Psychiatrists and the College of General Practitioners. So I guess it's, in a summary, a statement, and the recommendations have been accepted by both specialist medical colleges as well as relevant stakeholders as well, which is gratifying that it's viewed as a practical document that can at least be implemented going forward. For those of you who can't wait to see it published, it is available on a preprint server. There are some minor changes that have had to be done to what is available on the preprint server as opposed to what will be published, mainly for kind of decreasing word count to make it fit within the MJA guidelines, and also probably a few, I hate to say, spelling errors and typos. But the consensus guideline statements and recommendations are unchanged. So those are still there, but this will be slightly different to what's published in the Medical Journal of Australia. So with regards to the future work and challenges of the National Prison Addiction Medicine Network, we're currently working on a consensus statement around withdrawal management and psychosocial interventions within the custodial setting, and trying to focus with the psychosocial settings, talking about substance use and relapse prevention. We're currently liaising with the Harm Reduction Prison Working Group about some projects, including a prison mapping project around harm reduction interventions in custodial settings. So just seeing what exactly is being done and how effectively it's being done in the different states and territories as well. And also trying to source some funding to keep the work going of the prison network. Currently, this is an unfunded network. All our members are volunteers, give up their time. And to continue to work, it's going to potentially need further funding going forwards. But in summary, the National Prison Addiction Medicine Network is a sector-led response to try and address some of the disparities we see in the care of people in custody who have substance use disorders and who are going through withdrawal as well. The current statement that we've just hopefully going to have published soon is what we hope would be a minimum standard for the care of people who are in prison with opioid use disorders. But there is still further work that is required to ensure that we can get some standardization of care within custodial settings. And that's not limited to addiction medicine. That's also with regards to mental health and medical issues as well within Australia. And again, to kind of develop, again, a national set of minimum standards, which Stuart has been talking about for some time now as well. But that brings me to pretty much the end of my presentation. There's some references to some of the statements that I've made, and I will stop sharing my screen and happy to answer any questions as they arise.
Thank you very much, Thileepan. That's a fantastic piece of work, and I was chuckling as you were talking about getting it done in a couple of months. I think anything in 9 months in academia is an extraordinary achievement. So congratulations and thank you again for sharing it. So we have quite a bit of time for questions, so I'll invite folks to put their cameras on if they're willing. I'd love to see your faces. And I'll just turn it over to people on the call for questions. Andrea, I see that you've got one. Would you like to just read that out and get us started?
Sure. Thanks so much for your presentation. Just checking you can hear me. Yeah, great. So I just had 2 questions. One is quite specific about the language of 2.3. I don't know if you want to bring that up just to make it easier for people to follow along. But just around the language there and the sort of choice around not having an absolute prohibition of withdrawal or discontinuing treatment as a disciplinary measure. And also, I guess, a broader question, which might not be sort of your field or area of interest, but whether there's anyone doing work in the police custody space, given that when people first come into the criminal legal system, it's through police custody, so they'll start withdrawing at that point. And obviously that's a health issue, but it's also a sort of human rights issue, because if people are in that sort of amount of pain and that unwell, that sort of might impact what admissions they might make during a police interview. Thanks.
Yeah. So with regards to, I guess, the wording of 2.3, which was the avoiding, withholding, or discontinuing OAT as a disciplinary measure, and forced tapering and withdrawal of OAT during incarceration increases risks of overdose and death on release. I'm just going to try and be careful with how I word this, but because this is kind of it's a national network, and there are significant differences of opinion about the provision of opioid agonist therapy and what it involves. And there's sometimes differences of opinion in terms of risk. And say I would view, for example, as forcing someone with opioid use disorder who is using other drugs as well while they're incarcerated as a risk of, worsening their outcomes from their opioid use disorder, for example, whereas other people sometimes view that this is a cumulative risk of, I'm very uncomfortable about, for example, giving a patient opioid agonist therapy while they're using XYZ. So there was some, I guess with National Network, you'll get some philosophical differences amongst the members. And I guess the wording ultimately for something like this, instead of a absolute thing, this was the thing that we could get some agreement on, or a consensus agreement. And I guess it goes back to my earlier point around this statement. Ultimately, these statements are what we could get votes on and could be used to advocate an agenda. And some of the more, for lack of a better term, people who are a bit more, say, progressive about their views of OAT are not completely happy, and the people who are a bit more, say, conservative about their views around OAT are not necessarily happy, but it's kind of that middle ground where people can kind of advocate for it. So would I like a complete prohibition? Yes, I would. Did we have the votes to get to it? No, we didn't. But did we feel that it was important to at least have a statement in here about withholding and discontinuing OAT and the harms associated with it? Yes, we did. So with regards to that, I think that's how the wording of the statement ended up where it is. Does that answer your question? And sorry, I've forgotten what the second part of your question was.
Thank you. I kind of suspected that might be the case, but just thought I'd throw the question out there. And the second part was around looking at police custody, because that's when people start to withdraw once they're in the system.
Yeah, ultimately, we feel that the statement is by and of itself applicable to police cells and watch houses. It's going to be interesting trying to advocate it, because even talking in the Victorian jurisdiction, which is where I'm at as well, the police cells are kind of governed by Victoria Police, which is a completely different entity to the people that manage all the other prisons, and they have their own withdrawal guidelines. And with what I've seen from the other jurisdictions as well, the police cells kind of operate in their own little sphere with minimal medical oversight, minimal medical support, and you're dealing with people in acute withdrawal at the most dangerous time period as well. There's probably a piece in there to advocate for more medical oversight in police cells in general, and actually having more medical personnel in police cells, because those are the high vulnerable time periods also. But we feel a lot of the statements here in terms of identifying people, they're universal. The question then becomes one of resourcing. Do you have skilled enough staff who can identify someone who's got an opioid use disorder, someone who's in opioid withdrawal? Can you get OAT to this person in a timely manner? And then that becomes more a resourcing thing rather than, I guess, the applicability of the standard. And it's difficult because in Victoria, there are, and this is, I think, publicly available information, but the care in police cells is somewhat medical, but because the service is largely Melbourne based, the further out you are from Melbourne, it's quite difficult to kind of get the same standard or level of care that you would probably get if you were in metropolitan Melbourne. And that would hold true for each of the states and territories.
Andrea, does that answer that question for you?
Yeah, thanks so much. Really interesting.
Yeah, thank you. It's a great question. I think we could probably spend a whole hour just talking about the police custody side of things. There's a whole thing to dive into there. Look, while we're waiting for other people to formulate questions, one that perhaps an obvious question is, now that we have these consensus guidelines, what scope is there to do some kind of auditing or benchmarking across the country with respect to those standards? It'll be really interesting to see.
It would be, and unfortunately, this is probably the thing about like standards in general in custodial environments in this country, which is that each of the states and territories does its own thing, and they're largely opaque and hidden behind doors. Some states are a bit more open than others. Like, so for example, you do see some more research and literature, say, coming out of New South Wales and a lot of the other states and territories. But it's going to be hard to clearly benchmark this without support from each of the state and territories' correctional staff to release this information. And that will probably be difficult. And that's almost another piece in terms of the need for national minimum standards, and almost, getting a report card system, somewhat like having these standards, and a bit like the closing the gap statement, where you kind of check every year how close we are to getting it. But that requires free and open transmission of information. And that has historically been difficult in this environment.
Very graciously said too, Thileepan. Did I hear somebody else with a question there? Oh, Lindsay, you're first up.
Oh, yeah, just that was in my mind too. So this kind of brought back memories of pre-2020 when I was living and working in Canada, and we did a very similar thing in British Columbia to develop performance measurement standards for opioid use disorder care. But we also had a population level data set in which we could, measure how the outcomes were actually occurring, and some of the standards and the performance measures. But yeah, it's pretty impressive that you did all this in 9 months, because I was in charge of coordinating that Delphi panel to come up with our performance measures, and it was a truckload of work, and it's really hard to wrangle all of the responses. Another thing that we did in that project was we used that data to look at the predictive validity of each of the performance measures for hospitalization and mortality. So I think that's another thing that could be done if the data was available, just to really drive home the point that some of these measures are really important and people should care about them and offer data to help measure them. But that's the perennial challenge, it seems, in the justice health space, getting the data to measure some of these things. But yeah, job really well done. I don't think I have a question on top of that, but maybe it's just more of a conversation.
Thileepan, did you want to quickly respond? Any response to that?
No, not really, other than thank you. And the fact that, yeah, it will be kind of good to see if we could, in real time or over time, record the impact of these statements, as well as the impact on if it has actually changed state and territory kind of regulations, rules, and patients' access to OIT. But then again, back to that, harping on about the same thing about national standards and recording health interventions.
Indeed, thank you. I think we have Margaret, then Louise.
Thank you. Thanks for all the great work, and kudos, given that it is a voluntary network and people are doing this on top of already pretty stretched roles, I would imagine. I was wondering, in terms of the kind of, I can't remember the exact language, the priority populations, if any discussion had arisen around those folks with serious mental health conditions who would be likely linking with community mental health centres, or, when they're back in, well, hopefully linking with community mental health centres or GPs when they're back in the community, and whether there was any opportunity to have that done in a kind of a co-occurring, competent way, because that's quite a lot of people in prison.
Yeah, it is. I think the rate of dual diagnosis that we're seeing as well is very high as well. By and of itself, we haven't talked too much in the consensus OAT statement. We haven't really talked about the mental health community on OAT in great detail per se. A lot of the stuff that we're talking about in terms of our dual diagnosis patients, we're probably going to try and put in our psychosocial consensus statement in terms of the interventions that can be done in prisons for patients with dual diagnosis. So that's probably one of our third bodies of work that we're aiming to probably focus on in more detail. We just thought we'd focus on kind of the more, I guess, lower hanging fruit, for lack of a better term, in terms of the OAT statement, just generic statements. But we are aware, we totally agree, and that other body of work will probably more target that population.
Thank you.
Thanks, Louise.
Yeah, thanks for a really interesting presentation. My thought was, it feels like the recommendations align pretty strongly with the those in the National Drug Strategy, which I just had a quick look at, and I see that that identifies people in criminal justice settings and people with mental health issues as priority populations for the purposes of the strategy. But I couldn't see anything in there really about the monitoring of, they've got sort of indicators identified, but nothing that really seems to pick up, obviously, the criminal justice settings. And I suppose it's more of a question. Do you think there's scope to perhaps do some advocacy or some work to incorporate your recommendations into the next iteration of the National Drug Strategy? The current one runs out in 2026, so it might be good timing to do some advocacy around that, given that it seems to very strongly align with the in terms of content and actions.
Yeah, absolutely. I think the next bit of work as well, other than trying to churn through a few more consensus statements, as trying to advocate for these guidelines, which we would argue are very kind of modest and non-controversial in many respects as well to be part of something like this. There's also an argument as well. The National MATOD guideline is very old as well. I think it was 2014 when that was done, and that's also probably due for an upgrade as well. It doesn't even include LAIB in the National MATOD guideline. But if that's also up to date, whether or not there could be a section about custodial environment within there as well, and then putting that in there also fits quite nicely. So the short answer is yes. We're just trying to figure out who to partner with. But to that end as well, I did show the panel of our expert committee, but it's subsequently expanded as well to include Hester Wilson, who's the Chief Addiction Medicine Specialist for New South Wales, and Paul McCartney, who's the Chief Medical Advisor for Victoria as well. So there's a bit more interest, I think, from some of the states as well to take part. And hopefully we can leverage some of our members to try and to get the outcomes that you were talking about. But yeah, absolutely.
And Thileepan, just for anyone who may not know, LAIB, I assume, is long-acting injectable buprenorphine. Yep. Cameron.
Oh, yes, thank you very much, Thileepan. It's really given an insight. First of all, I'm just speaking as a non-medical person, but I'm wondering whether non-withdrawal of OAT during incarceration is controversial at all. I understand that there's the risk of overdose upon release, but if it's affecting the health of patients, is that monitored? Because I didn't see too much about monitoring of whether the treatment continues, but maybe because of that 2.3 approach to go again to avoid removal of treatment.
So are you asking, do we have a section in how to manage people coming off opioid agonist therapy while they're in custody?
Yes.
Yeah. Not necessarily. We don't have it in this guideline, mainly because the management of people coming off opioid agonist therapy is usually somewhat the same regardless. So it's kind of essentially withdrawal management, which would be largely symptomatic. We didn't focus on withdrawal management in this consensus statement because this is purely about opioid agonist therapy. Our next bit of work is the withdrawal management consensus statement, and we'll probably have a lot more around what should happen in terms of opiate withdrawal, alcohol withdrawal, benzodiazepine withdrawal, etc., in that statement by and of itself. But with a OAT guideline statement, we were more focusing on identification, commencement, and going through, because essentially we would not really be, there would be very, 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 very few cases, you never want to say zero, but close to zero, as to why you would stop OAT in, like, especially involuntarily within a custodial setting. So it didn't really kind of make sense in this statement, but there will be something on opioid agonists, withdrawal from opioids in our withdrawal guideline.
I see. Yeah, probably why I'm asking is doctors are quite often, justice health doctors are quite often quite remote from whether a prisoner is still socialising and other factors, like that. And I'm just wondering, whether there would be an approach to increasing that sort of feedback in some ways.
So you mean in terms of continuing OAT?
If prisoners on OAT were, for example, sleeping all day and becoming more aggressive, yes, whether there's an approach to that.
Yeah, I think in general, these statements were kind of, they don't replace, like, say, for example, the national MATOD guidelines, which would govern, like, the how you kind of increase doses and things. So it doesn't say this is not prescriptive in you start at X dose and you increase by X, Y, Z. This is more a statement on kind of the philosophy per se. But with regards to your question about if a patient is sedated while being on Matod, that's kind of readily, easily manageable in terms of if the dose is too high, then that's a different setting. But if there's some other medical process going on, that also needs to be investigated as well. So this statement doesn't say replace the national Matod guidelines, but it kind of serves more as a statement of people should have access to OAT. People should be maintained on OAT ideally throughout. People should be maintained on OAT whilst they're in custody and continued on OAT post-release. But the management of sedation, a dose being, say, too high for a patient, would follow the standard guidelines you get in the community.
I see. Oh, thanks. Yeah, that makes sense. So thanks a lot.
Thanks, Cameron. It sounds like the issue there is just about making sure that there's a feedback loop for people whose dosage may not be appropriate to make sure that, that there is management that's in accordance with the Matod guidelines. I think that sounds like what we're saying. Hands flying up everywhere. We have Lindsay, then Andrea again.
Yeah, I'm just on that point. It's got me thinking. I'm just looking through the recommendations in detail, and the one just around offering. I mean, obviously we know it's good to offer people OAT if they have opioid use disorder. But two things, we also know that there's a really high risk of death if people stop taking OAT, because then they're really vulnerable to overdose. And the other thing that we know is that there's really poor continuity of care after release from prison. And obviously there's a recommendation as well to help, facilitate that continuity of care. So I'm just wondering, and this shows, my lack of ignorance of the health services, but, also understanding that there's often a disconnection. So people that are placed on OAT currently in prisons, is there any supports that they receive to make sure that they get their follow-up or the next kind of script or medication in the community, or is it kind of like they're released with their script for the next couple days and then it's like good luck? Because I mean, I guess the other alternative is you go through withdrawal and you're also vulnerable to overdose once you come out because your tolerance is really low. So yeah.
Yeah, great question. And the short answer is it's variable. Every state and territory does things differently. And even within states and territories, depending on where you are, there's quite big differences. Some places will proactively try and source a community OAT provider for the patient and then try and ensure that there's a bridging script that will last the patient until they see their OAT prescriber. Some patients, unfortunately, I have heard of cases, and in addition to the work I do in the prison, I do a day a week at a place called HealthWorks in Victoria, which is like a primary care service for people who use drugs. And certainly some of the people that we see coming in from places you hear different stories basically as to the availability or the access people have to supports. And that's different in each of the states. So unfortunately, there's no uniformity in terms of how people access their support and their ongoing OAT scripts post-discharge, which is, again, probably the need for why we need better, say, transitional care clinics or transitions from prisons, which are integrating people back into the community, both socially but also medically, and making sure medications aren't rapidly discontinued as well, because it's not just OAT, but like, say, if your psychotropic medications are stopped all of a sudden as well, that's also a disaster as well.
Yeah. And I guess as well, like a lot of people, don't know where they're going after release. So you have your script and then, how do they know who to reach out to help support this person? It's so challenging.
Absolutely. And people are also discharged unexpectedly, going to court and bailed or whatever. So this also adds layers of complexity to the whole thing. So it is a very difficult and fraught environment. But unfortunately, there's no uniformity, and people can still be left in the lurch.
Yeah, it's really interesting. It raises a lot of, questions around responsibility and morality that we need to support people, but then there's also it's irresponsible, it seems, to provide a medication and then not have supports to continue it, because we know that puts people at risk. Not that that's an excuse that we shouldn't offer it to them, because we should, but just reveals how important that transitional care aspect is in this specific instance.
It's complex indeed. Thanks, Lindsay. Mindful of time, Andrea, over to you.
I guess you've kind of touched on this. I was going to ask about unexpected releases from prison, for example, when people are granted bail. I mean, I think parole's a bit easier because hopefully there's some information flow in terms of someone's coming up for parole potentially. But yeah, if you're kind of aware of any better practices preparing people where they're going to court to make a bail application, especially given how many people are on remand in prisons at the moment versus sentenced.
Yeah, look, I'm not aware of like a gold standard or brilliant like coordinated approach. I've certainly seen or heard of individual places where people are more, I guess, proactively treated. But yeah, it's difficult because there's also so much opacity around how people are transitioned into the community. And there's very few low barrier OAT access points for patients. A lot of the time, if you're even going through, say, a hospital or a public hospital clinic, you still have to try and make an appointment. There's a wait list. You might not get seen at the time that you expect to be seen as well. And then if we're talking about parole, like you said, theoretically, you'd hope if you've got an end date, you could organise an appointment. But with the unexpected discharges, it is difficult. I've certainly heard of cases where, and sometimes some people have tried to advocate for more access to LAIB, long-acting injectable buprenorphine, just because of the greater time period people can be on it. So the longer time people can potentially wait to access a community OAT prescriber. But then that also undermines patient choice in terms of the fact that people are entitled, in my opinion, to have a choice of the kind of OAT formulation they want. But that's really a long-winded way of saying there's no brilliant system that I'm aware of for patients who are discharged on short notice to access OAT unless there's pre-planning. And I think that just goes to point of we should have low access transitional care clinics, or people should be linked into transitional care clinics whilst they're incarcerated. And then when people are unexpectedly discharged, at least they'll have some access to some support into the community. But long story short, no.
Thanks, Thileepan. That's, we don't have time to dig into this, but it raises that really interesting issue where healthcare providers in custodial settings, at least in Australia, seem to be situated as contracted providers rather than key partners, and are therefore recipients of all of the challenges of that system rather than active partners in mitigating those challenges. So there's certainly room for some large structural and cultural change, but maybe that can be your next piece of work after the one that you're doing now. Look, I might, since there's no hands up at this moment, I might take the chance to ask another question. I was really interested in recommendation 5.4 to have a statewide electronic medical record, which I think is a fantastic idea. I wonder if you could just very briefly elaborate on some of the thinking behind that, and if you're comfortable, perhaps reflect on the challenges in somewhere like Victoria, where there's such a disaggregated service provision system that might be particularly challenging and important.
I think there's two things there in terms of like in Victoria we use J-Care, and I think all the custodial settings in Victoria use J-Care. But as with most electronic medical records, and I think Victoria is a good example in the sense that even say with our public hospital systems, we all use electronic medical records, but we don't use the same electronic medical record. So you don't have any knowledge or oversight if someone's gone to another health district or region about what kind of help they've received. And that's certainly the same with J-Care as well, where J-Care records are not accessible in the community, and you have to ask for release of information to access health notes, health summaries, medications, etc. So it's also, I think about having an electronic medical record that is accessible to community healthcare prescribers to know what has happened whilst someone's been in custody, what healthcare that they've received, what doctors or specialist care that they've received, what medications have been commenced or discontinued, and if are there any outpatient appointments that are still outstanding that the patient will need to attend post-discharge into the community as well. So a lot of the jurisdictions do seem to have like state-based electronic medical records, but the issue became how well does that serve the patient when they're removed from custody? And for those where the electronic medical record was site-specific, it was a no-brainer to advocate for at least a state-based custodial health record. But I think we need far more in terms of making sure patients are cared for along the spectrum of both in custody and out of custody.
Thank you. I mean, of course, we could spend a whole hour on that, and it sounds, if I could summarize, there's challenges there about ensuring coordination and shared information across custodial settings within a jurisdiction, but also critically between community and custody, and that sounds like the more challenging of the two.
Absolutely. Yep.